Hello, everybody. Welcome to Nuclear Medicine Academy, Session 1. I'm Dr. Kai, and with me is Dr. Ziad today from Amman in Jordan. Hello, Ziad. So, how's life going in Amman?
Good. It's pretty hot. It was 42 degrees a couple of days ago. Now it dropped to 37, but it's still hot.
Okay, great. So we oversee the first 2 or 3 weeks of our Nuclear Medicine Academy. And so far, we have good feedback on the cases and on the lectures. You prepared very nice lectures. I'm sure our guests have seen some teasers on the social media platforms. And today we are planning to learn something from you. We will see some cases, and you selected 2 topics. Can you tell us about the topics that you selected?
So we have actually a nice collection of PET and MSK SPECT cases. They're really interesting, and I chose the ones that I think would benefit anyone who reports FDG PET CT and whoever is interested in MSK SPECT CT. The PET cases. Probably they're not something that you see every day, but we're gonna discuss these cases and how to group a couple of findings that doesn't make sense, and how to try to, and we're gonna try to make sense of them in order to come up with a differential diagnosis, and maybe some will learn a different approach to PET scans. I know a lot of nuclear medicine physicians, they approach their scans in a different way. So maybe it's something new for some, and maybe I hope it's going to be beneficial to them and in their routine reporting and their daily practice. We have really nice cases, PET cases, and we have two difficult MSK cases. I'm hoping we're going to have time to discuss them.
Okay, I will show briefly how to access the platform. So this is my browser. This is basically the welcome screen. This welcome screen, those who are already enrolled in the Academy have seen it. They got an email how to enter. All our guests today on YouTube and LinkedIn can take a note of this URL. I also will post it in the comments, and I will also have a QR code that I will place here in the corner where there is a logo. That will take a little time, so you can scan this QR code, and after that you can access the cases, the nuclear medicine cases on your mobile device, like a tablet or a phone. So this is the QR code. If you scan that, you are coming to the welcome screen that you see here. What you have to do is you enter your name and your email, click on Join Now, and then you are in the platform and can scroll through the cases. And on the platform itself, you have 2 options. We have this, show you the next step, which is basically this screen, where you see we have 2 tiles. We have the prepared cases, and this first one is the live stream. So if you're already seeing the live stream on YouTube or LinkedIn, you do not need to click on the first tile. You click on the second one. If you are on our Academy, you already have started the view here, the live view in this tile, and you click on this. And then we have these cases here, which you can open, which you can use for scrolling. So you can go through the cases, you can read about the cases, but Ziad will explain everything. You do not need to bother about it. So if you have some questions about certain things, you can also talk to us. We have a chat box in the streaming software that you can use. You can ask general questions, and also we have the possibility. I need to share this one. Sorry. again, I do this mistake all over again. So if you are here with this the live stream, and these are the cases, you click on the second tile, you have the cases here, and you see we have prepared 5 or 6 cases. We don't know if time is giving us a chance to see all of them. You go to the case, you can mostly see about the history. You can click through the cases and scroll it and try to analyze. Sometimes you have these summaries at the end of the case, and if there is something that is especially of interest to you, you can use this button over here, this pin and comment button, and if you click it, you can place this blue pin and place it here, confirm the position with the mouse, and this also works on your mobile device, by the way. Confirm this pin, and then you can ask, is this normal or something else? So this is really interactive, and you can ask pixel by pixel and learn, and you see we can see what you did ask, and we can answer it in our stream. So that is all of what you need to know from my side. I will now ask Ziad to share his screen to walk us over the first case.
Can you see my screen?
I will do it. Sorry, I will do it. Now we can see your screen. Yes, wonderful.
So we have 6 cases. And we have 3 PET cases, and we have 3 MSK SPECT CT cases. We're going to start with the first PET case. And this is a 49-year-old male, and he had a vague abdominal pain and discomfort. He did a CT scan, which showed numerous hepatic lesions without other clarification, and they did not state any other findings in the report. And he was referred to do the FDG because they couldn't figure out what was wrong with him, and to assess for a primary lesion. Now, this is the MIP, the PET MIP. As you can see, it's a bit granulated. This is not the best of quality of PET image. We'd like to see this as a homogeneous color or uptake. And if you just look at the MIP scan, you can maybe dismiss it as a normal scan, but we need to look further. So this is, I'm gonna put up the axial PET, and we're gonna link it with the CT. There was nothing much going on in the chest and thorax. This is just normal myocardial activity. And in the neck, there was nothing interesting, no thoracic lymphadenopathy or chest axillary lymphadenopathy. And when you look at the liver, it's a bit enlarged, and this is just a soft tissue window. This is not a liver window. You can see that there are discrete hyperdensities over here, and there are geographical hyperdensities as well. So we have numerous hyperdense lesions occupying both liver lobes. And when we look at the PET, we don't see much activity. There are areas of mild to moderate uptake. And when we look at the lymph nodes in the upper abdomen, you can see, for example, here we have a small lymph node. It's a bit rounded. We have also hepatic hilum lymph nodes. And this is probably showing mild uptake, mild to moderate uptake. I think it was moderate uptake. Anyhow, we have upper abdominal lymph nodes, and we have these hepatic lesions. Now, we're going to take a look at the hepatic window when we finish this series. And we don't see any retroperitoneal compartments lymph nodes. We don't see any mesenteric lymph nodes. The bowel, it looks fine. And when we go down to the level of the rectum, so at the first glance, when I saw this case, when I looked at this uptake over here, I just dismissed it as a probably normal physiological uptake. But when you look very close, you can see on the CT part over here, there is a bit of fat infiltration. I think there were tiny or subcentimetric lymph nodes, pararectal lymph nodes. And when you look at the activity over here, you can see that in this hotspot over here, it is not what we usually see in a physiological or inflammatory condition. Usually, when the bowel is collapsed, especially the large bowel, when there's physiological activity, it's basically confined within the submucosa. For example, if we look here at the rectum, you can see that this part, the uptake is within the submucosa. It's not involving the wall, but here you have this uptake, and you can see that there is a focal thickening in the rectum over here, and we have this fat infiltration. So when we look again at the liver window, we can maybe see the liver lesions in a better way. And as you can see now, we have numerous variable-sized hyperdense lesions, hepatic lesions. Some are showing mild uptake. For example, this is here showing a bit of uptake, and it is involving both lobes. So what we have here, what we're looking at is probable rectal lesion. And let me just go back to the rectal lesion. So we probably have an abnormal uptake here in the rectum. There is a bit of thickening, and we have mesorectal or a regional fat infiltration. Now, and if you look at these volumes here or at this series, you can see this is how basically I do my reporting. You can use these templates, or you can do your own. So the liver, it was actually a bit enlarged, and we have numerous hyperdense variable-sized lesions. The intensity of uptake, it is subjective. I don't follow the SUV. I rely on what I actually see. So I called it as mild to moderate. I think there were areas of moderate uptake, and we had a prominent sized upper abdominal lymph nodes. Some of them were showing mild to moderate uptake. I report the lesions with the lowest uptake and the lesion with the highest uptake. So I always give a range. I don't just state the maximum or the lesion with the highest SUV max. And we have, as we saw, left anterolateral rectal wall focal area of intense uptake with adjacent fat infiltration. So this is how I do my conclusion. Again, it is the same as what we talked about. And here, if you look here, this is a really nice addition. So you can see a summary of this case and the learning points. So this patient, he did not say that he had a colonoscopy. This is why I said that a lower endoscopy is advised. He actually had one. And when the referring physician called me, he told me that he actually had a lower endoscopy, and it was normal. They took multiple biopsies, and there was a polyp in the descending colon, and it showed low-grade dysplasia. However, you should always trust your eyes, and you have radiological evidence that there is probably something abnormal here. Again, when I see this uptake, it is traversing the wall, and it's not just confined to the submucosa. You should think that there is pathology, underlying pathology. And with evidence of fat infiltration around this region, you should really think that there is an underlying pathology. So they reviewed the biopsies, and it was actually a well-differentiated neuroendocrine tumor. He also had a liver biopsy, and it was also a neuroendocrine tumor. And in these cases, rectal neuroendocrine tumors, usually they do not metastasize unless it is a high grade or it's big enough. I think the cutoff, or if it's more than 2 centimeters, usually there is a high risk for metastasis, and the most common site of distant metastasis is the liver. So when you see these findings, you have to make sense. They need to make sense. You have a probable rectal lesion, and it is showing uptake with the radiological evidence that there is an abnormality there. and you have these hepatic hyperdense lesions. These are not, definitely they are not cysts. Definitely there is a pathology there. So you have, and they're showing low grade or mild to moderate, or you can even call them mild uptake. And you have to think of neuroendocrine tumor in these cases. And it was actually based on my opinion that they reviewed the histopathology, and it was actually a neuroendocrine tumor. So what we need to learn from this case is not every uptake in the bowel is physiological. When you see something outside the pattern that you're used to or you commonly see in the physiological conditions, you have to think that there is an underlying pathology. So here, and if you go through these, if you go through this volume, you can see that there are teaching points about FDG, the role of FDG PET scan in neuroendocrine tumors, especially in the rectum. We're going to add another volume to this to do a summary about neuroendocrine tumors. And here you can see the limitations of FDG PET in these cases, and basically a summary of this case, and how to report these findings and how to write your conclusion based on your findings.
So how do you tell that is a higher uptake? You mentioned it one or two times, and one of our participants is asking it.
I do visual assessment. I don't use SUV. I do visual assessment. So it depends on what I'm looking at. If it's, for example, a lymph node or a lesion in the abdomen, I check the background activity. If it's higher than the background activity, I don't usually use the liver as a reference unless the patient is overweight, because this can overestimate the SUV values. And if there is dose infiltration and we can't repeat the scan, in these circumstances, I use the liver as a reference. In lung nodules, for example, first I take a look at the background activity. If it's higher than the background activity, then if it's higher than the mediastinal blood pool activity, this is when it becomes suspicious. Sometimes I call it mild. And then if it's higher than the liver activity, then I would go between moderate to intense uptake, depending on the visually how it appears. But I never rely on the SUV max, because I can get mild uptake in some lesions, and I'm sure a lot of nuclear medicine physicians saying the same problem. You see a mild uptake in a lesion, and the SUV max is 5 or 4.5 or sometimes 6. So do you call it a mild uptake, or do you call it intense uptake based on the SUV? Some colleagues, for example, one of my colleagues, he would never call something a lesion intense unless the SUV max is higher than 10. So it depends on what you're used to see, on how you approach the images. Personally, I rely on visual assessment unless there's a criteria, of course. For example, in lymphoma, we use the DeVale criteria, so that's a different story. You have to use the liver as a reference. But for generally speaking, for lesions, mainly I check the background activity. If it's higher than the background activity, then if it's higher than the liver activity, I would go between moderate to intense uptake.
Very nice. So you get immediate feedback here. And another question came in. How do we differentiate this NET from rectal cancer?
You can't. You need histopathology. I can't differentiate neuroendocrine tumors from adenocarcinoma. You need histopathology. But in this case, the liver lesions, you can say they're a bit typical for neuroendocrine tumor metastasis, and they were not showing uptake. So the first thing I thought of was actually neuroendocrine tumor. Now, even though that the activity is intense, which goes with high-grade tumor, but the reality is you don't have a definite cutoff between a high-grade and low-grade and moderate grade. You always have a heterogeneous distribution of the lesion within the organ. So you can have moderate to high-grade, low to high-grade, and basically tumors. So Based on, I can't see. Okay.
I have it.
Okay.
will
Yeah.
check.
So, because I need to go back to this lesion. So basically, this is probably involved as well. So here you can see intense uptake. Here you can see milder uptake. Now, can I differentiate this from adenocarcinoma? No, I can't. But I can't make a definite diagnosis. But based on the pattern of the findings, the hepatic lesions with low activity, and here we have intense, here you have mild activity, probably part of the rectum is involved as well. It is not showing uptake. So it's basically a heterogeneous lesion showing regions of high grade, regions of low grade. So this is why you see this difference of uptake. Some of the lesion probably is beyond the resolution of PET as well. So you see this heterogeneous a pattern of uptake, but a definite diagnosis, you need a histopathology. But based on the patterns that you see, you can make a most likely diagnosis. Nonetheless, he needed an endoscopy or to repeat the lower endoscopy.
So what's the resolution of a PET? You briefly mentioned it. How low can you go?
Commercial cameras, the reported spatial resolution is between 0.4 to 0.6 centimeters. This is the reported PET resolution for commercial cameras. Of course, if I see another question, of course, if you do a contrast enhanced CT, this should light up. Definitely, it should light up.
Okay, and this question that is on the stream now, hypervascular on target, I don't really know how to better word it. Maybe you write the question again. It's what do you mean, Imane?
I think on MR, if you do a contrast enhanced MR or contrast enhanced CT, yeah, they should light up. They should show diffuse enhancement. Usually, neuroendocrine tumors show diffuse enhancement.
Okay. So this question we had in our recent stream about if you do contrast enhanced CT with the PET or unenhanced CT.
No, I just do oral contrast. We don't do contrast enhanced CT unless the referring physician asks for it.
Okay, so it depends on the indication a bit and a bit on who is sending the patient.
Yeah, exactly. We don't do contrast enhanced CTs unless the referring physician, because most of the patients they were usually they come after they do the contrast enhanced CT. They are referred for PET. Regarding this patient, I don't know if he had a contrast enhanced CT, but to my knowledge that he did a CT. They did not mention anything that was going on in the rectum. Actually, when I first looked at this case, I missed this uptake when I saw it again. When I went through it again, it was really intense. It was not normal because, again, this is basically how I look at it. So this is the rectus sigmoid, and here you have, this is the sigmoid, for example. And when you see physiological activity, you should see it like this within the submucosa. It is not involving all the wall. But if you look at this part, okay, so this is, it looks like it's traversing the wall of the rectum. And here, this is how we physiologically see the uptake within the rectum. It is submucosal usually. But this, as you can see, it is traversing the rectal wall.
Okay. So I think it's worthwhile to go to the second case because time is running.
Yeah. This is what I was afraid of that's going to happen. So, okay. This is a nice case. Actually, I had this case a couple of days ago. We're going to go through this quickly. A 21-year-old male, and he had a history of fever of unknown origin. He had intermittent fever, and he complained of back pain. And he had many consultations. He did a CT scan. I did not see the report or the CT. It was normal. And I think he did a lumbar MRI because he was complaining of back pain, but there was nothing abnormal in the scan. And this is the MIP. So if we're assessing for primary tumor or fever of unknown origin, I always do a whole body CT scan. I need to see the whole lower limbs. I don't do to the acquisition to the mid-thigh. We do a whole body scan, as you can see. So just by looking at the MIP, there is a mild uptake in the axial and appendicular skeleton. I don't know if it's going to be visible here, but let's, so you can see this is, okay, this is the myocardium, okay? And here you have this uptake. It looks like a circumferential uptake. Now, if we look at the PAT in the axial slices, okay. So you can see this uptake here in the ascending aorta. This is the aorta, okay? And let me just see. Okay, so this is, if you look at the CT over here, this is the left ventricular outflow tract. And this is basically the ascending aorta. You can see there is a bit of respiratory motion or cardiac motion. There is a bit of motion over here. But when we look at the PAT, you can see that there is uptake involving the ascending aorta. And this is the aortic arch. It is also involving the aortic arch and part of the descending aorta as well over here. And there was nothing else interesting in this case. So when I see this, you have to think, of course, of vasculitis, aortitis. So you have to look at other organs, especially the lungs. We look for nodules in the lung, especially cavitary nodules. If it's a rheumatoid arthritis, usually we see them in the basal segments or in the lower lobes, and they don't show. Sometimes they can show intense uptake, but usually they don't show significant uptake. And the abdominal aorta was fine. You have to look, of course, at the bone, at the insertions of the ligaments. So basically, you have to think of a systemic disease. You have to look at every organ that might be included in an inflammatory disease or autoimmune disease, or any kind of inflammatory disease. And here we can, if we look at the coronal, we can see this is the ascending aorta, and it is showing uptake. Actually, the branches of the aortic arch are also showing uptake. And in the sagittal, you can see there's also uptake here, and this is part of the descending aorta. The proximal part, it is also showing intense uptake. This is a really nice case of aortitis. Now, in this case, there was no diagnosis for this patient. Here, again, you can see how I described this case: hypermetabolic circumferential uptake involving the walls of ascending aorta, arch, and proximal part. And in these cases, usually in vasculitis, or mainly in vasculitis, we use criteria that is explained here. So let me, basically it's visual grading. So grade 0, there's no uptake. 1, it is less than the mediastinal blood pool. And 2, it is more than the mediastinal blood pool, but less than the liver. And 3, more than the liver. So if you look at this case, if we go back, you can see here there is the uptake is a bit higher than the liver.
Can you enlarge this a bit for us with the Zoom tool? And maybe shift it up. Yeah.
I think now it's clear. So we have this uptake here, and it's relatively higher than the liver activity, and it is definitely higher than the mediastinal blood pool activity. Now, even though the criteria is some use it for established diagnosis of vasculitis, but actually you can use it if there is no diagnosis to suggest that this is actually might be aortitis or vasculitis. So here we can see this is the uptake in the walls. It is circumferential. It is involving the wall. It can also be patchy, but the most common appearance or presentation is usually a circumferential diffuse uptake in the walls, and it is definitely higher than the mediastinal blood pool, as we said, and it's relatively higher than the liver activity. So this is why, this is why I said it is highly suggestive of inflammatory aortitis. So in these cases, I don't say it is consistent because I don't have an established diagnosis, but this is most probably.
But we have already a good suggestion. If you see it, Takayasu would also be my guess. It's a young patient.
Yes, yeah, definitely, yes. It could be a Takayasu, but this patient, he needs further evaluation based on these findings. If you look at the, let me go back to the whole body. The MIP, actually, I think it looks better in the MIP. You can see that the vessels, sorry, in the upper and lower limbs, they are showing also uptake, but to a lesser extent than the intensity in the aortic walls. So it could be Takayasu, definitely it could be Takayasu. This patient, he needs further evaluation to basically find the actual diagnosis. It has a very high predictive value. I think it is for large and medium vessel disease, of course, not small vessel disease. I think it is above 95%.
Well, that's a lot. So
yes,
if that is negative, there's almost.
But the thing
is that vasculitis is ruled out.
Yes, and you need to make sure that the patient is not under cortisone or steroids therapy, because some of these patients, even though they don't have a diagnosis, the physicians, they start them on a steroid therapy and they get better. So they send them for a PET scan after starting the steroids. And if they are on steroids, you can end up with a false negative scan. So you need to stop the steroids for at least 7 days before doing the scan.
We had recently in our hospital a case. There was diffuse but intense signal coming from the muscles of the arm, of the forearm, and of the thigh. And in the report, it was mentioned this is increased muscle tonus. Can you say something about muscle tonus and how to avoid it and how to cope with it?
Okay, so basically we tell the patients that they should avoid any kind of exercise 24 hours before doing the scan, because yes, it can show a very intense uptake, especially if the patients go to the gym and they work out before they come to do the exam. You can end up with muscular scan. Basically, all of the uptake is within the muscles, so you can't interpret this. You have to do it again. So we tell them to refrain from any kind of exercise for at least 24 hours before doing the scan. This is a must. Yeah, this is a must. You can't avoid this. You have to.
And that means if the patient is not reading the material or is not listening and goes to the gym, that's just a waste of money, because you cannot evaluate anything in that scan then?
Yes, you cannot interpret the scan because all of the biodistribution of the FDG will be changed, will be altered. So it will go to the muscles instead of going to the actual pathology. So it will be obscured in these cases. Actually, I think this patient, he had uptake in the muscles. No, I thought he had uptake in the muscles.
Yeah, maybe we find such a case and make like a pitfall.
Yeah, and one final thing about this case. So you can see there is mild diffuse uptake in the axial and appendicular skeleton. You can see the bones. This is mildly increased, and this is his ESR and CRP were elevated, and this is expected as a reactionary response. So you see this diffuse pattern of uptake in the bones, basically.
How about the salivary glands?
No, you can see them under normal conditions.
And can they show up as a false negative finding?
Regarding the salivary glands, for example, in sarcoidosis, because I had a lot of patients with parotid glands involvement, you have to look at the CT part. If it looks nodular or the margins are nodular, or if you see, you don't think this patient doesn't have any of these findings. But nonetheless, usually the the contours of the glands, they're irregular or nodular, and you can see intraparotid lesions within the deep and superficial lobe. So, and they show intense uptake. So you should think that there is salivary gland involvement. If you have asymmetry on CT between the submandibular glands, you should also think, or any or asymmetrical heterogeneity between the submandibular glands, you should think of involvement in the disease. But basically, you have to assess them on the CT part if they
But that
show.
means this, if you show the fused version, the intense uptake in the salivary glands and the lymph nodes of the hypopharynx, this is everything normal here.
In this case,
Yeah, if you go to the fused axials, yes.
No, this is actually normal activity. So here you have the parotids. This is normal. This is normal physiological activity. And here we have the submandibular glands. Here we have the sublingual glands. This is a normal physiological activity. This is not something concerning. I look at the CT part in these cases. I don't rely on FDG unless there is asymmetry. If it's homogeneous and symmetrical uptake, it is most of the time it is just normal activity. If you need to do characterization, soft tissue characterization, you need MR. So I cannot 100% exclude that there is no disease involvement. For example, if this was sarcoidosis, I cannot exclude with 100% that the parotid glands, for example, they're not involved if it is not showing uptake on the. Most likely it's not, but you need MR in these cases.
Okay, let's go to case number 3.
Okay, so case number 3. This is a sarcoidosis case. Okay. So this is a 48. This is a pretty straightforward history. 48-year-old male, and he had progressive shortness of breath. He did a CT scan, and they found a right pulmonary mass. So they just referred him to do the FDG PET scan without any further investigations. So this is the MIP. And when you see this sign, I know a lot of nuclear medicine physicians, when they see this relatively looks like a lambda sign, which is a classic for sarcoidosis. But you know that these are mediastinal lymph nodes. Probably here we have axillary lymph nodes. Here supraclavicular lymph nodes. You have a lesion here. You have one here. You have one here. So what are we looking at? We're gonna start with the axial. Okay, they should be. I should be able to link them anyhow. We have bilateral cervical lymph nodes. So you can see here we have a lymph node. This is in level 3, and these are in level 5. If we look at the CT, let me try to look them up. So we have this lymph node over here. And if we go down, we have in level 4. So basically, we have bilateral supraclavicular lymph nodes, and they're prominent sites or variable sites. Some are small, some are prominent. We go down to the mediastinum and thoracic inlet. So we have a lymph node here, and we have multi-regional mediastinal lymph nodes in the upper paratracheal above the aortic arch, and we have prevascular lymph nodes. I think we saw one up here, and below the aortic arch, this is lower paratracheal lymph nodes. Level 4 are bilaterally. We have subcarinal, and these are hilar lymph nodes. As we know, these are the subaortic AP window nodes. And so basically, we have multi-regional mediastinal lymph nodes and bilateral hilar lymph nodes. And we also can see here a small internal mammary lymph node. It is showing mild uptake. And let's take a look at the axillary lymph nodes. So here we have axillary lymph nodes. This is level 1. This is below the lateral edge of the pectoralis minor. So here we have level 1 lymph nodes. And here, posterior to the pectoralis minor, we have level 2 lymph nodes. And level 3 is medial to the medial part or edge of the pectoralis Minor, I don't see. Probably this. There's a subcentimetric lymph node over here. Let's take a look at the CT. We have a lot of lymph nodes. Okay, so this is in level 1 and level 2. These are all below the pectoralis. And we can see a bone lesion here. There's a bone lesion here, and another one here, and in the ribs as well. We're going to take a look at the CT part. Let me just remove this. And going down, we have this nodule here in the left adrenal gland. It is showing uptake. So if you look at the CT, so it depends on the what CT acquisition that you do. I do a diagnostic dose CT with a 2 or 2.5 millimeter acquisition. I know a lot do 5 millimeter acquisition, low dose non-diagnostic CT, but I think you can't actually make a diagnosis if you just want to do the PET scan and for just reporting hotspots, just saying that there are a bunch of hotspots somewhere. Okay, but if you want to do a diagnostic, if you want to solve the problem for the referring physician or the patients, you have to do a diagnostic CT. So here, even with the diagnostic CT, without this is of course without contrast, this is the adrenal gland. There is a bit of thickening, or maybe if we can adjust the contrast, so you can see that there is. Okay, this stopped working. Okay, now it's working. There is a lesion here in the right adrenal gland, nonetheless. So here you can see the muscular activity in the abdominal wall.
Yeah, that's normal.
You can see. No, you shouldn't see muscular activity. No, this is not normal. We shouldn't see muscular activity. And we have a lesion over here as well. This is the greater trochanter, posterior part. You have uptake here, and in the acetabulum. So let us take a look at the lung, because this is why the patient was referred. Okay, this is not working again. Okay, great. Okay, so this is the lung window, and I hope I can. Great, I can leave them. Okay, so in the apices, we have these clustered nodular opacities on the peripheral, and they're showing none to mild uptake, because here you have a bit of uptake. And we're going to take a look at the HRCT after we finish this. And here there is minimal uptake. So we have a clustered nodular opacities of none and mild uptake in the apices. And when we go down, so basically this is why the patient was referred. You can see this central or peribronchovascular consolidation. There's a bit of ground glass surrounding it. It looks like it has irregular margins, and it is showing intense uptake. So here you can see the intense uptake. You can see how this is extending. So this is peribronchovascular consolidation with surrounding ground glass, and there is a bit of narrowing in the lumen of the. Let me go back. Okay, this is the superior lobar bronchus. You can see this is the whale sign or the hump sign. So this is how we know we are in the upper lobe or the upper lobar bronchus. And you can see there is thickening surrounding the segmental branches. And here we can see a bit of fissural thickening. But I like to look at the lung, and if there is an HRCT, it can give you a clearer idea of what's going on. So these are the nodular opacities. They appear much better now. And we go down, you can see this is the consolidative opacities. So it looks like there is a sign called galaxy sign. Basically, you have coalescent nodules. They form this appearance. It is irregular, surrounding ground glass. And you can see a tiny pulmonary nodules adjacent to this consolidation. And here you can see there is fissural thickening and nodularity a bit, especially here. You can see that there is thickening. So I like these cases because to me they are straight forward. So how do we describe? We didn't look at the bone. So we have, let's look at the bone very quick. And we have, okay, so, okay, so here, I think I discussed this case on my channel. So we have this uptake here, and you can see there is focal cortical interruption or low density. So this is probably a lytic lesion over here, and it is showing intense uptake. And here you can see clearly there is a lytic lesion, and it is showing uptake. Let's go down in the ribs. There is uptake, and you're gonna tell me there is nothing there, but I will show you that there is a most probable lytic lesion. So you can see that there is an abrupt cutoff over here, and you can, if you adjust the contrast, you can see the margins of this lytic lesion over here, and it is showing uptake. And here we have, this is probably marrow uptake. I don't see much going on here. And we have, I think there was another, there it is. We have this lytic lesion over here. And we saw, I think if we, yeah. So I'm going to go through this quickly because we don't have much time.
This means you are regarding this as a bone manifestation of sarcoid.
Yes, yes. This was actually sarcoidosis. He had a biopsy. This was a sarcoidosis. So you have an uptick in the acetabulum. This was a lytic lesion. And the greater trochanter that we saw it earlier, this one, there was a focal cortical interruption. So how do I describe this case? Basically, it is the same as I always do. You don't have to say always hypermetabolic, but this catches the eye of the referring physician. They always look for keywords in order, because they're not going to read the whole report. So we have supraclavicular lymph nodes, axillary, mediastinal, and hilar lymph nodes, and we have also an internal mammary lymph nodes, and we have the pulmonary peribronchiovascular consolidative opacities. It was showing intense uptake with irregular margins. We saw the tiny nodules on the HRCT. They were not visible on the standard PET CT acquisition. And there was also, we saw the fissural nodular thickening, and there was a lesion in the adrenal gland. This is basically how I describe my PET report. And in the conclusion, you can either state each system alone in a different point, or you can cram them up in a single paragraph. Everyone prefers a certain approach. So we have, because the primary was the reason for referral was the right pulmonary mass. So it's a hypermetabolic consolidative opacity. And we have the lymph nodes that we talked about. So I always add 3 differential diagnoses in my conclusion. I don't do more than 3 differential diagnoses. I knew it was a sarcoidosis because I saw this a lot of times. I see a lot of atypical presentation of sarcoidosis, and I think with PET, the incidence of sarcoidosis, it is increasing, because most of the times that I usually see, it is atypical presentations of the disease. So to me, it was suggestive of sarcoidosis based on the radiological appearance and the pattern of lesions. Of course, you cannot exclude lymphoma, and you have a right lung mass, so you also have to think of pulmonary carcinoma. And this is the history of the patient. You can go through it, and a bit of learning points describing the role of PET in sarcoidosis. This is very just a couple of points. And what you should remember is that sarcoidosis can manifest in many different ways. I had a patient with splenomegaly and diffuse uptake, and it was actually sarcoidosis. I had another patient with numerous lesions in the skin, some showing uptake, some not showing uptake. It was actually a cutaneous sarcoidosis. So you, in my opinion, you should always think of sarcoidosis in these cases, especially if you get referrals with unknown diagnosis, or the referring physician don't know what's going on with these patients. So just keep it in your mind. And yes, bone metastasis, yeah, definitely. It would show the same appearance. It's lytic. So sarcoidosis, it can be lytic or it can be sclerotic as well, but it can be lytic, and yes, it mimics a bone metastasis. That's why I had to include pulmonary tumor. Regarding the cardiac uptake, this was not a well-prepared patient, so you can see there is diffuse uptake. I cannot assist the cardiac involvement in this case, but I had a patient, we did the whole body scan for sarcoidosis as well, and the cardiac activity was suppressed, and there was a focal area in the basal part of the septum. So it was cardiac involvement. But in this case, I cannot assist for cardiac involvement. You need to redo the scan with cardiac protocol. You have to put the patient on low-carb diet for at least 48 hours. 24 hours is not enough. You have to do at least 48 hours and do a cardiac protocol. So I cannot assist the cardiac activity in this patient.
So cardiac preparation needs days in order to.
Yes.
Yeah.
You have to put the patient on low carb, high protein, high fat diet for the recommendation is 24 hours, but in my opinion, you should do it for at least for 48 hours. 24 hours is sometimes not enough. The salivary glands, they look fine. I don't see any uptake in the salivary glands, and you have to look also, but they're not included in this case. I'll upload the other case. And you have to look at the orbits, at the rectus, especially at the rectus muscles, because it can be involved, and you should assist them for asymmetry or soft tissue fullness in these cases, especially in sarcoidosis.
Okay, great. Thank you, Ziad. Very nice explanation, very, very comprehensive. So we have about 9 minutes left, maybe 8. What next case would you recommend?
Yeah, we can do the cervical disc arthroplasty. I think this is a nice case. I don't know if anyone ever saw a similar case. So we can do this one, I think.
Okay.
Because it is shorter and it has an MR, so you can help me with that. So this is a 39-year-old female. Basically, long story short, she had surgical intervention, anterior cervical discectomy and fusion. And after the surgery, there was still pain and it was getting worse. She did an MR, and I included it here. I think there is an MR report as well. So she was referred to do the SPECT CT. I was consulted in this case. These are not this was not done at our centers, and this is the MIP. Unfortunately, they did not do a blood pool phase. I always like to do a blood pool early phase SPECT CT. This is just the delayed, and you can see this hotspot over here. So let us take a look at this patient. I should, sorry, okay, I should do this one. So this is the bone window, and here you can see this is the cervical disc hardware, and you can see there is intense uptake involving the superior end plate. This was C5, I think. Let me just check very quickly. C6, sorry, C6. This was C6, and so here, if we have this intense uptake, and if we look at the CT part, you can see there is a bit of osteolysis and degeneration, or you can call it cystic degeneration, for example. And this is all showing intense uptake. There's a bit of sclerosis, and it is all showing intense uptake. You can see here, probably, let me just adjust the contrast a bit. You can, if this was a better CT acquisition, we would have probably have seen an osteolytic or a lucent line over here. So we have this uptake, we have these changes along the end plate. And let's take a look at the coronal. Okay, so you have, if we look at these images, we have here, you can see that there is a bit of osteolysis over here compared to the contralateral side. If compared to the contralateral side, of course, this is just a stress shielding, and it is not showing uptake. And this is definitely pathological uptake. This is not normal uptake, especially after a couple of years of the surgery. So This is the MR report. I don't know if you agree with it. Did you see the case? Did you take a look at it?
I relied completely on you because on you know the case. The MRI.
No, I mean the MR images.
No, I didn't look at it. In fact.
Okay, so basically what we have is intense uptake at the superior endplate of C6 and corresponding cortical osteolysis, cystic changes, and sclerosis. There's a subtle lucency line at the bone prosthesis interface. I think if it was a better CT acquisition, we would have definitely saw that. And there was a zone of osteolysis at the right margin of the prosthesis. I'm going to show you this again. And this part over here, there is an artifact, of course, but there is a bit, let me just show it to you because this can be very subtle if this is not good quality CT. So here you can see that there is a bit of osteolysis compared to the contralateral side. This is just an inflammatory, this is just stress shielding, and this is all explained here. So we have inflammatory and non-inflammatory osteolysis. Non-inflammatory osteolysis, usually it involves the periphery of the vertebral bodies, and this is normal due to stress shielding. It usually involves the anterior border or the margins, as we saw medially. And inflammatory osteolysis, it occurs along the endplate, and you need to see these CT changes or osseous changes that we saw. It can be also mild, moderate, and severe, but this is always pathological. So this patient needs further evaluation, surgical evaluation, and this is the MR, and this is an artifact because of the metal. And do we have a significant stenosis over here, or this is not significant?
I mean, there's this metal artifact, and
Yeah.
the posterior space is still well preserved, so that is not a significant stenosis.
It wouldn't explain her symptoms because she's in severe pain. Yeah, so basically this is an inflammatory osteolysis. I don't know if there is similar...
Actually, I found the CT images quite good. The metal artifacts are minimal. So
yeah.
Yeah, because here you see them more, but on the coronals, or here this one looks quite good.
It is a bit good, but I don't like to do this is 1.25 millimeter acquisition. I usually, in the case of prosthesis, I do one. You can do, of course, 1.25, but I'm used to seeing much more details with lower, thinner slices. But there is the osteolysis that we talked about. It is definitely here. And it is showing intense uptake. So this is an inflammatory osteolysis, and this is pathological.
Okay, so we
can we do the foot case?
We have Imane asked about the foot case. Our time is up somehow. Lots of artifacts. Yeah, there are some artifacts. Yeah, that's true. So yeah, would we do the foot case on the next session maybe?
Sure. This is this. These are the feet of the same patient.
Yeah. Maybe we pull it together as a lecture, or we put it as in a live session in September, because I think we should stay with the time. And I also would like to briefly mention that if you go on the Berlin Case Viewer site, you have the option to go to the Nuclear Medicine Academy. We have two case collections. We have the full collection with MSK cases, pulmonary cases, and a little bit of cardiac cases for the radiologists, and for the nuclear medicine physicians. We have this separate Nuclear Medicine Academy, and you can also find both of them here in the menu, because these links, they might be changed over time. And very nicely, you can also filter here between videos where you just watch and learn, and you have the case collections where you in fact have multiple cases. So for instance, here these are 3 cases, and here we have even 10 cases in one collection. So that is something you should think about.
We have a lot of cases. We have a lot of PET cases as well.
Yes, and we will of course expand our offering. So Ziad, what's on your list? What you record next?
I'm gonna finish recording PAT cases this month, video lectures explaining the PAT cases as we did in this session. Then the next month, I'm gonna start doing like a mini course for PET-CT anatomy, describing the anatomy in details. I hope this is gonna be, I'm gonna finish this next month, and I'm gonna keep recording a lecture, a video discussion of the cases every week. So the participants should expect at least a new video case discussion every single week, and we're constantly uploading PET cases and MSK cases. We have actually a lot of cases that we didn't add still to the app yet.
Cool, very nice. So thank you all for the positive comments. Also, we had one guest today, Imane from UK, who was the most active one. Also, she already has a crown on YouTube as she's our most active participants. Very nice to see all these repeating guests coming. And cool. Thank you all very much for joining by, and enjoy your afternoon.
Thank you for having me, and thanks for everyone.
Bye-bye.